joining us today. Harold was going to mention a new initiative that the American Lung Association is proud of, and it's our COVID-19 Action Initiative. And it really is a 3-year investment to end COVID-19 and prevent future pandemics. And the work that we are going to be doing with this action initiative will fall under our research, education, and advocacy of the organization. And we work under those 3 branches for all of the programs that we provide and all of the work that we do here at the organization. And so we're very proud of this initiative, and we know that you'll be hearing more about that in the future. Our next speaker is Dr. Albert Rizzo, and Dr. Rizzo is the Chief Medical Officer for the American Lung Association. Dr. Rizzo is responsible for ensuring that the American Lung Association is always using the best science and medicine to formulate and deliver on our mission. Dr. Rizzo is a member of the ChristianaCare Pulmonary Associates in Newark, Delaware. Dr. Rizzo?
Thank you, Deb, and thank you all for joining us today. What I thought I'd do before we turn it over to our other experts and go into more deeper conversation about the testing, I just wanted to lay some basic groundwork around coronavirus and virology in general. And unfortunately, we know that COVID-19 has been challenging for us. It's a new virus, and it's zoonotic in nature. It's coming out of animals like many of the other coronaviruses have. And most of the time, the coronaviruses we've been used to have been the common cold. However, as you can see from this slide, those 4 common colds did not get fancy names. Once we had SARS back in the early 2000s, then MERS, and now SARS-CoV-2, we have coronaviruses that are much more lethal to humans and much more severe in their nature. What you see on the side there is a graph that shows that most of these coronaviruses seem to come out of bats, and then they transition to another animal before they spread into the human population. SARS was with civet cats, MERS was with camels, and the feeling right now is that SARS-CoV-2 may have come out of either cats or possibly the pangolin, which is a scaled anteater. We all know that the coronavirus started out as cough, fever, shortness of breath as the main symptoms that made people seek help. We now know that the coronavirus has been involved in much more of the physiology and organs of the body than just the lungs, although the lungs are primarily involved because it is the point of entry for most of the infections that occur. And you see on the right now that it has involved kidney failure, cardiac disease, individuals develop blood clots. There's even effects on the brain and COVID brain, and different terms are coming out of this. And we're learning more and more as we go by that the physiology of this virus is acting a little bit differently than a virus compared to influenza. We also know that unfortunately there are people who are at risk for developing the complications. We're all at risk for developing infection. That's why we all have to take the containment issues and mitigation issues very seriously. But there are those in the population where once they're infected, there is a higher risk of complications. And sometimes this becomes important when we start to decide about who should get testing and what kind of testing should be done. We'll talk more about that as we go through the rest of these slides. But the foremost way to try to contain any pandemic has to do with containment by way of what's called the 3 T's, or identification or testing, and then isolating those individuals found to be positive and treating them if there is treatment. In COVID-19, it's mainly supportive at this time. And then very importantly, tracing the contacts. And if it can be very effective in this phase, it can also sometimes lead to not needing to use the mitigation phases that you'll see on the next slide. The quote that I put there underneath the graphic was a recent quote from the World Health Organization, who was seeming to downplay the fact that this could be spread from asymptomatic individuals. And I think there's been some retraction or reanalysis of that statement, saying it's not the main way that this transmission has occurred, really to emphasize that containment and mitigation tend to be the best way to control the spread of the virus. You've seen charts like this repeatedly over the last several months, and really what it meant to say is that once containment was not effective, we need to slow down the rate of infection of the population so that we did not overwhelm the healthcare industry. And if we could contain it and keep it at that lower curve, individuals would still get sick. Unfortunately, they would still need hospitalizations, but the workforce and the supplies would not be outstripped. And in order to do that, we had to mitigate with the work at home orders, social distancing, closing schools, and particularly canceling large events where a number of people would be together, especially in enclosed areas. And to put a little perspective on this, we talk about how do viruses cause infection and where do the droplets come from. And if you see on this slide, coughs, sneeze, and even just breathing can release droplets into the air. Cough certainly at a little bit slower rate than sneezes, and that then therefore means that these aerosol droplets can sometimes stay in the air a little bit longer with a sneeze and certainly can travel a little bit farther. Even just breathing can sometimes end up putting droplets into the air that can be infectious. And as you note at the bottom of this slide, about 1,000 SARS-CoV-2 viral particles are assumed to be needed for an infection to take hold. And each cough, as I mentioned up there in the middle of the slide, has about 200,000 viral particles in each droplet. So it can be very infectious. And besides the numbers, we also look at what's called the R0 or the R factor for viral spread. This is a number that indicates how readily does this infection spread from the case, in the first case, the one person, into others around them. If you notice on the chart, measles is highly contagious. For every one person, they can infect another 12 to 18 individuals fairly readily. Influenza is more in the 0.9 to 2 range, and currently the ranges for SARS-CoV-2 are between 2 to 6. Ideally, we hope happens for a pandemic to be slowed or to peter out is to have that R value less than 1. And the way we do that is usually with vaccines. And why we do that is that there's a term called herd immunity. If you see in the top slide, that blue section, the individual that's infected in red, if there's no immunity in the population, the number of individuals who get infected via a virus that has a high R factor is very high and becomes very pandemic in nature. As soon as you have a population that becomes vaccinated, as on the lower part, the infected person in the red circle has very few other people they can spread the virus to. So herd immunity by way of vaccine is a way to try to keep people safer and to slow down the pandemic. We don't want herd immunity to occur by natural cases because a lot of individuals would get sick, a lot of individuals would be in that category of critically ill and unfortunately die. So that's why it's important to use testing to help not only contain, but then also determine how do we use these tests to mitigate further spread, and certainly how do we use these tests to prepare for the next pandemic. And there's basically two types of tests we're going to discuss. Dr. Moore will go into a lot more detail. We're going to talk about viral detection, which is the test that determines if you're currently infected, and then importantly determining serologic antibodies, or did you have an infection and now do you carry antibodies that may or may not be protective for future infection, and that's an unknown at this point in time. The FDA currently has two types of diagnosing the COVID-19 as far as the viral test or detection test, the molecular and the antigen. The molecular test gathers material usually by way of nasopharyngeal swab that is pictured on the slide, and that's put into what's called a PCR test, which amplifies the number of viral genes that are determined there based on the 4 genes that are listed on the slide. And by way of reagents and equipment, the test is either determined to have the viral particle present or not. The nasopharyngeal swab is a little bit uncomfortable, but probably it's best if it's uncomfortable. It means you were getting a good specimen from the back of the nasopharynx. You can also use oral throat swabs, sputum, bronchoalveolar lavage, and tracheal secretions, and each of those have their advantages or disadvantages, and each test has its degree of sensitivity and specificity. The newer test that the FDA had approved is called an antigen test. Unlike the molecular test, which measures the actual genetic codes and the nucleic acids, the antigen test is more specifically looking at proteins related to the virus. This is also a nasal throat swab. The main drawback is that even though it's faster and less expensive, it's not always as accurate as the molecular test. If it's positive, it's very good, but a negative test often needs to be confirmed by way of a molecular test. Once we've had the virus infection, the body has been exposed to proteins and nucleic acids in the coronavirus. As you see here, there are a number of proteins listed, and these proteins are what our body's immune system recognizes and starts to use what's called the adaptive immunity to develop plasma cells and antibodies and even some T cells that are part of the immune system to begin to form a memory immunity, so the next time we're exposed to a similar virus, the body can respond more quickly. The antibodies that form around coronavirus tend to be around the spike or the protein that attaches to our airway. There are also some related to the capsule. And depending on how these studies are done, different antibodies are determined as part of the test. And the FDA has cleared the serology test as being an immune response test, but at this point in time, all it says is there was an infection with the coronavirus, and it doesn't necessarily confer immunity. And as I mentioned early on, there are other coronaviruses that all of us have been exposed to as part of the common cold, and sometimes those lingering antibodies can sometimes cross-react with tests that can give false positives as to regard a COVID antibody. Lower down on the screen there, you see what's called neutralizing antibodies, and those are what are ideal to determine if we have that antibody response. That's the response we want to see for preventing future infection. So as I turn it back to Deb, I hope by the end of this discussion, we're going to be able to see how we can use these tests clinically to help treat our patients. More importantly, how do we use these tests to help from a public health standpoint to mitigate the disease? And then what have we learned so far? What do we need to learn further to help make sure we're ready for the next pandemic? So I'm going to turn it back to Deb so we can have further discussion from Dr. Mora and Dr. Osterholm.
Thank you very much, Dr. Rizzo. So we're going to ask each of you to take another moment to participate in a brief survey asking, have you ever been tested for COVID-19? Okay, it looks like some of the members, our participants, have been tested using a nasal swab. So thank you for participating. At this time, our next speaker is Dr. Juanita Mora, who is an allergist and immunologist in Chicago with a strong interest in asthma care and breaking down barriers to asthma care in underserved communities. In 2014, Dr. Mora opened up her own practice in the Chicago Allergy Center and works with a very diverse community in Chicago. She is a clinic partner with the American Lung Association in Chicago, Illinois. Dr. Mora?
Hi, thank you for having me here. It's such a pleasure to be here today. And I want to definitely talk about the SARS-CoV-2, and I've been doing a lot of antibody testing, especially as we are reopening the country. And I wanted to talk about where does it actually have a role as we are opening state, and where can we use it clinically as well too, and some of Dr. Rizzo's actual comments as well too. And so we know that SARS-CoV-2 antigens are used for antibody generation, and there are 4 different types of coronavirus structural proteins. And the ones that we definitely are going to concentrate on are, the antibodies are geared toward, which are the spike protein with the receptor binding protein, which is called S1RBD. And that is the most specific. It actually tells you, it makes it the most different in COVID-19 in comparison to other coronaviruses. So it increases the specificity of your test. Your nucleocapsid actual protein is the most sensitive when it comes to detection of antibody. So when we talk about antibody testing, it usually goes towards those 2 actual structural proteins. And when we talk about antibody testing for SARS-CoV-2, and we're talking about the actual landscape, we know that there's a lot of actual antibody tests out there. And one of the things that I really want to hone on is the actual testing landscape. And there's an actual website that I actually mentioned called the Coronavirus Test Tracker. And you can actually Google it. And it tells you all the companies currently throughout the country that are trying to make diagnostic tests for coronavirus as well, too. And when we talk about actual antibody testing, there's 8 actual tests. And this is from the FDA website, 8 different commercial tests that are currently available for antibody testing with different specificities. Back in March, these 8 companies actually got emergency authorization from the FDA, and one of them actually got the full green light, which is the Roche test, ROCHE, with the 99.9% accuracy, which is the one actually I've been using in clinic to help a lot of people get back into the workplace, and I'll talk about it in a few minutes as well too. So where is the application of the antibody testing in clinical practice? So some of the advantages or possible advantages of actual antibody testing, one is in public health surveillance. It can help inform society how many asymptomatic cases have occurred, for example, serostatus in specific populations. So here in clinic, I've been helping a lot of the Latino community, especially where there were outbreaks, for example, in the workplace or deaths in the workplace as well, too, and kind of seeing how widespread this the disease actually was. And then another population that's very interesting is children. So about 25% of children are actually asymptomatic when it comes to COVID-19. And I've been finding in clinic and actual screening, a lot of kids have actually been testing positive for a cold they had back in January or February or March or even late December. Because I think this virus, honestly, now that I'm doing more antibody testing, started late November, beginning of December, that it entered actually the country. The other thing that it's going to be important for is in vaccine development. So it's in verification of vaccine response once antibody correlates to protection are identified. So currently with the antibody tests that we have, there is no protective or antibody correlates for protection at this time. But once we hopefully have a vaccine development, we can actually use the antibody test to make sure that you beautifully responded to the vaccine and then have protection. So that's coming in the future. The other actual forward thinking that is coming as well too is detection of PCR negative cases. So there's some nasal swabs that we might actually miss as far as positives or they're false negatives. One thing we know is from studies that have come out of Wuhan, China, and from South Korea as well too, is that in people who have day 0 to 3 of symptoms or from the start of symptoms, day 0 to 3, there's a 0% sensitivity in the actual antibody test. So the antibodies will actually start developing around day 5.5 after symptoms begin. So this is going to be important as we continue to actually reopen the state and see how prevalent this disease is. The other one is in identification of convalescent plasma donors for those who are truly sick. One of the things I've been doing in clinic is for those people who some were intubated and they actually came to get actually antibody testing so that they could become plasma donors and help the truly sick. So it's been an amazing 360-degree turnaround as well too, where people get to help those that were maybe in their similar situation as well too. So, and I'm trying to do a lot of African-American plasma, Latino plasma as well too, because they're needed in these banks as well too. And then contact tracing, as Dr. Risso actually mentioned as well too. And this I'm doing a lot in workplaces. There's a Tortilleria Milagro here in Chicago. They had 8 deaths within the company because unfortunately they didn't do social distancing or actual face cloth mask or anything. And a lot of the workers afterwards, the company closed for 2 weeks, and we did specifically this, where we tested the workers and saw which ones actually had the disease, but maybe didn't even have symptoms or anything else. So that way, as we introduce people back into the workplace, they know whether they had it or not. But again, not actually to show that there's any protection or anything else as well too. And this is an actual nice graph for the actual antibodies. So IgM peaks at about day 12 and persists about 35 days. So first you have RNA. So the RNA, so coronavirus or COVID-19 is an RNA virus. So your RNA starts to peak at about day 5.5. Actually, IgM, which is the first antibody that shows that you have an acute infection, starts coming on. It peaks around day 12 and then persists about 35 days. Then comes IgG, which is your actual marker that says, I've actually battled COVID-19 and now, I actually have had it. And that is IgG. That peaks around day 17 and persists for about 49 days. We know from SARS-CoV actual data that IgG lasts about 2 years, and that's coming from that data itself from previous studies. So areas of uncertainty is, for example, this is the most common questions I actually get in clinic. So for example, one is, Dr. Mora, do I have immunity because I have positive antibodies? And just as Dr. Rizzo said, no, we can't say that the antibodies correlate with actual immunity, because we haven't proven currently in science which actual correlates do actually equal to immunity in COVID-19. But what it does tell us is that you at one point had COVID-19 and are now actually, your body shows that you had it. And the other thing where it actually, another big question I always get as well is, can I get reinfected? Does it equal immunity? So the World Health Organization, actually at the lower bottom there, it says, actually, they addressed this specific question because they were asked, well, if they're antibody positive, does it mean they have immunity passports? And does that actually equal immunity passport in COVID-19? World Health Organization, again, came out with a statement that said, no, it does not equal actual immunity, and people have to be careful. The other thing is, it comes into ethical and legal issues as well, too, is people who are antibody positive and maybe are more cavalier as well, too. They feel like maybe they don't have to continue social distancing or face cloth masks as well, too. But what I remind them is that it's a novel virus, right? So it can mutate again and again. Previously, from when we started back in the data for China, all we knew is that it affected a lot of adults, especially older adults. Suddenly, we became the immunocompromised as well, too. Then we saw the cases coming out of New York for kids as well, too. So as it mutates, it affects different populations. Can it mutate again? Absolutely. Can people get it again? Yes, they can. And so we don't want people to let their guard down. The other thing is, as people get reintroduced into the workplace, a lot of companies are saying, well, go get the antibody test so we know whether you've had it or not. But what we don't want companies to actually think is, well, that they're going to be more likely to hire the people who have already had coronavirus because they have a positive antibody test, and that way we can be more cavalier. We don't have to be as careful, etc. Or, the other way around, that the people who have not tested positive for coronavirus or are COVID antibody negative, well, these are the people we keep in the office, and we're going to be a lot more careful, etc. We want everyone to remain actually vigilant when it comes to social distancing, face cloth masks, good hand washing, and the use of hand sanitizers, especially in the workplace. But those are some of the actual big scenarios that I've encountered that, definitely lead you into a little bit of ethical dilemmas and so forth. But all we can do as physicians is do these recommendations as well, too. The other thing is they've actually looked at the different antibody tests currently on the market, and the left graph is from the UCSF study that actually showed they pretty much correlate pretty well as far as the different types of antibody tests. On the right, I found this graph that was really actually wonderful, and I like to point it out because what about antibody actual levels that are higher versus those that are lower? So one thing they have found in studies that correlate nicely is that people whose antibody levels are higher were the sicker actual patients. So they were the patients who might have been intubated, who were in the ICU for 3 weeks, etc. And then those with the lower levels correlated with milder disease as well, too. And I have seen that a lot in clinic now after testing thousands of people, actually, and this is how I got into it, which I think is completely interesting. And here's what the antibody tests won't tell you. For starters, the antibody tests are only a sign of past infection. Whether the infection is actually gone can only be determined by a diagnostic test that identifies genetic material from the virus or viral particle. Some people also falsely think testing positive on an antibody test proves that they can't get infected with the virus again. But again, it's a novel virus. It can actually mutate. You can get it again. Antibody testing could provide researchers with valuable information, definitely, for studying overall trends in the epidemic, such as how many people in the community have actually been exposed to the actual virus, which I think is one of the actual areas that I'm really working on as well, too, now. As actually the types of serological assays and performance that are currently being done on the market, we have the rapid diagnostic test, which is, for example, like one coming out of China, that's actually a little blood test into a well, and it basically takes about 15 to 30 minutes to run, and it's like a pregnancy test basically, because it tells you, it gives you a line if you're IgM positive or you have active infection. It gives you a line if you have IgG positive, which is, you know, do you have antibodies present? And then there's a control line as well too. Not as exact. Then you have the ELISA, which is, for example, the Roche test, the 99.9% accuracy, which is basically a quantitative measure of antibody levels. And then, as Dr. Rizzo mentioned as well too, then there's actually the viral culture itself that can actually be done as well too, but that's not done very often because it's a lot more labor and expensive, et cetera. So this is kind of where we're a little bit headed. So I had to put Dr. Birx's picture on because and Dr. Fauci should have put a picture of him too, because we've heard them speak so much about actual testing and where it's going. One of the big things is definitely antigen testing, which along with antibody testing is going to increase your sensitivity and specificity of COVID-19 antibody testing and reintroduction of people into the actual country. When you think of antigen testing, think like rapid strep. So rapid strep is, you know, definitely something that we use a lot in the office, and we actually can tell a child or an adult you have it or you don't. Same thing is what is currently being thought of for antigen testing as we reopen the state, because it will give you more of the prevalence of the actual disease as well too, which is going to be very important as well too. And one of the things in summary that we have to say is that antibody testing can help us navigate the pandemic, i.e. helping to identify people who have already been exposed to COVID-19. Like this person, I tell people maybe who have been exposed to COVID-19 that they can become the designated grocery shopper in their family. So that's as cavalier as I get. Antibody testing can also give us a good idea from a public health perspective as far as how widespread disease is, and especially in specific populations like children, Latino community, African Americans, all the minority populations as well too, which is really great. Antibody testing can also help us guide back to the workplace, especially in those with widespread disease, to help identify contact tracing as well too. Antibody testing is also important in helping to identify convalescent plasma donors for those truly sick, which I think is one of the biggest advantages of antibody testing. And antibody testing will play a great role once a vaccine is developed, crossing our fingers that it's soon, because then we can actually see if people are responsive to the vaccine and creating those antibody titers that show us that they have protection. And remember, people who are actually antibody positive can still get reinfected with COVID-19. It's too novel of a virus, and protective correlates have not been currently identified. And the last note I'll actually say is people who are antibody positive should continue good practice of social distancing, mask, and hand washing.
All right. Well, thank you, Dr. Mora. We really appreciate you joining us today.
You're welcome.
At this point, I'm going to go to questions. Whoops, I believe, is Dr. Osterholm able to join us?
Yes, I am.
Oh, great. So our final speaker of the day is Dr. Michael Osterholm, who is an infectious disease epidemiologist. He's a Regents Professor and the Director of the Center for Infectious Disease Research and Policy at the University of Minnesota. He has served as a special advisor to the Federal Department of Health and Human Services on bioterrorism and public health preparedness. He was also appointed to the interim management team at the Centers for Disease Control and Prevention in search of a new director. He is a frequent guest lecturer on the topic of infectious diseases. He serves on numerous medical journal editorial boards, and he is frequently a consultant at the World Health Organization, the National Institutes of Health, the Food and Drug Administration, and the Department of Defense and the Centers for Disease Control and Prevention. Dr. Osterholm?
Thank you very much. And first of all, I apologize I'm not with you on camera or you have access to my slides, as I had a connection problem getting in, and so you're just going to have to put up with my voice, and hopefully I can give you the information that you need. Our center has been very involved with the COVID issue dating back actually into December of last winter. And in January 20th, actually put a document out indicating that this would cause a worldwide pandemic, laying out the issues. One of the other areas we've been very involved with is testing. I've written a number of pieces on it. And there's a document that you can find on our center's website. The center's website is for CIDRAP, the Center for Infectious Disease Research and Policy at the University of Minnesota. The web address for that is www.cidrap.umn.edu. That's www.cidrap.umn.edu. And the heart of my conversation today with you is going to be about this particular document in the CIDRAP viewpoint entitled basically Smart Testing. And this is what we really need to talk about today. There's a lot of information out there about testing that I think is unfortunately not well based on science, and I will share with you today where we come from on that. The document that I mentioned on smart testing was published some weeks ago, and it basically lays out that effective testing for SARS-CoV-2 will require a concerted effort that combines laboratory testing technologies with other critical components to optimize the U.S. public health response and includes increased testing. That may sound like a mouthful, but what you're going to see in a minute, it's not just about the test. Far too many people have misinterpreted testing as just about the test. It's the entire testing environment. And while we need to greatly expand our SARS-CoV testing as a critical element in our response to COVID-19, the pandemic messaging to date needs to move well beyond test mantras. That is the wrong approach. When Willie Sutton was asked why he robbed banks, he said that's where the money is. I'll come back to this in a moment and say we need to be aiming our testing at very specific targets in terms of populations and how these tests are used. And you'll see in a moment that the ability to test for SARS-CoV really depends on a cascade of elements essential for optimal testing. It's not just the test itself, but it's the entire system as all put together. And it really must be strategic and its focus. And unfortunately today, that's not been the case. Now, when we come up with the idea of a smart testing process, if I had the slide in front of you would see, first of all, we need the right infrastructure. And what I mean by that is basically we need to have the overall supply chain availability in place and understand that just having a test by name doesn't mean you actually have a test in use. We've had major challenges with reagents from around the world. And the fact that the whole world needs them at one time. We've had companies with great fanfare announce new tests and then not be able to provide the kind of support with reagents that we need. I can tell you as the chair here in Minnesota, the governor's working group on testing and public health, we continue to have major challenges with reagents because the world all wants these same reagents. The other aspect, of course, is sampling. For example, just the swabs and the difference in types of swabs you use can make a difference of up to 4 to 5% on how frequently you pick up a positive or not and what that means. So you have to have all that in place. Then in addition, you need to have the right equipment. One of the things that we've not appreciated is that to date we've been using basically the same number of testing machines with only a slight improvement in that over the course of this pandemic testing. These machines were never meant to go 24/7, 365 days a year, and we're beginning to see an increasing number of machines breaking down where the supply parts are coming from Asia or Europe. And we've now driven, you might say, this new car at 100 miles an hour for the past several months, and we're all beginning to see what happens when you do that. That, again, has to be part of a smart testing system. Then you have to get into the right population. Testing must be targeted based on the goals of testing. For example, and I mentioned the Willie Sutton example, the people we need to test most today for the actual virus are those who are clinically ill with as soon as possible after onset of symptoms that could possibly be COVID-19. That's where we're going to find, number one, what the real incidence of disease in our communities are. Number two is we're going to identify hotspots. Even if we don't see all the patients, if we see a cluster of cases in an area, that can tell us a lot about what it might be happening in that community. many people have just said test, 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 just as we just tested millions of people every week. And you'll see in a moment with the combination of false positives and false negatives, that's not at all the way we should be going. And this document lays this out in some detail about the need for the right population. I'll also make some comments about the issue of antibody testing after Dr. Mora's previous comments about where we ought to be testing there or not testing and the challenges with that. Then we need the right test. I wrote about this issue in the New York Times weeks before the White House finally figured out that the antigen tests that they were using there at the White House had a number of false negatives, meaning people really were positive when they were supposed to be thought to be negative. And in fact, that is not what you'd want to use at that point. That is not the right test by itself. It surely could give you a quick result, but as you heard earlier in the discussion from Dr. Rizzo, it's very important that you have a backup test for that. I can also go through other tests for today. The antibody testing remains a wild, wild west situation. I'll share that more with you in a moment, and why, in fact, we discourage a lot of the antibody testing as it is today because of the erroneous results that we're getting. Then you want the right interpretation. What is the test sensitivity and specificity? Today, we estimate that about 5% of the U.S. population has previously been infected with this virus. Clearly, it's higher in some localized areas, such as New York City. But in a very low prevalence environment, testing takes on very different outcomes in terms of what the predictive value of a positive or predictive value of a negative is. And so that we have to understand what sensitivity and specificity is all about. And then you want the right action based on the test results. We've heard of a number of events, for example, where there have been the drive-by testing event, where at the end of the day, there may be hundreds of positives that are obtained in that particular testing for the day, with results not able to be returned because up to 50% of the samples did not have adequate names, addresses, telephone numbers, or emails. That is wasted testing. That is really not smart testing. So the SARS-CoV testing really has to be a cascade that considers all of these different issues. You have to look at labor. You have to look at the issue of protective equipment for people taking the samples. All of that, if you don't have the whole thing in place, material capacity, instrument capacity, skilled labor availability, instrument use availability, result reporting and action steps, what you're going to do to follow up on it, a test is wasted. Anywhere along that line, it's like the chain of infection itself. If you break that chain, you end up having a situation where you are not successful with what you're doing. In our report, we laid out the right population. The decision which tests are appropriate should be driven by epidemiologic context and by the risk to both the individual and the public of both false positive and false negative results. The detection of a SARS-CoV-2 in people with symptoms is clearly very, very important. And we need to have as much of that done as possible. Then next to the prioritization should be detection of SARS-CoV in people without symptoms but who have recently been exposed. And that, too, is very important. I hope, if nothing else, everyone is learning that having a positive PCR test for this particular virus, SARS-CoV-2, in of itself does not mean that you're infectious or, for that matter, infected. There's been a lot of discussion in the last couple of weeks of people who are supposedly chronically infected with repeated PCR positives. And we know today that by the time you get to the 8th or 9th day post-onset of your infection, the likelihood of actually isolating virus drops dramatically. What you will, however, do is pick up viral debris, which could be picked up for potentially weeks to months. We have seen many people who have been harmed by that whole issue in terms of not being able to go back to work. We've had mothers whose children were in the NICU, that they were infected and ill at the time of delivery, who 2 months later still are showing some PCR positivity, not able to even go visit their own child. This is terribly unfortunate. The CDC will be making more statements about this soon, but just because you find PCR positivity after 9 or 10 days of illness means nothing necessarily about where we are. Finally, I just want to say a few things about SARS-CoV antibody serology. Dr. Moore and I may not probably agree on this. This is, in fact, to me, the wild, wild west, as I mentioned. To date, there are 18 emergency use authorization approved antibody tests on the market, and they vary in their sensitivity and specificity. More importantly, there are over 200 that have reported to the FDA that they're going to be distributing their test without being validated. And they can do that under the current FDA oversight. Only 30-some tests have actually been said by FDA to be so bad that they could no longer be marketed. And in this testing, we see a variety of different sensitivities and specificity. And let me just give you a very standard situation. Assuming a 5% seropositive rate, basically that's what you would expect, with a 95% sensitivity and 95% specificity, if I basically sampled 100,000 people in the state of Minnesota or in many places in the country, I would find just as many false positives as I'd find true positives, meaning 50% of all the positives would in fact not be true positives. That is, so how do you tell someone you're positive, but we don't really know what it means yet? Plus, on the other hand, we have a 1 out of 2 chance not really being positive. And as long as we have this wild, wild west in serology, I think its use should be very, very limited primarily to surveillance, where we can systematically take into account the issue of sensitivity specificity, meaning that if I'm sampling the same population over time, the error rate that goes into the sensitivity specificity is going to be in each sample. So if I do see a doubling or a tripling of the percentage that are positive, that gives me a sense that that's really what it is. I think right now the idea of immunity passports, telling people what these results mean, is really not responsible. And I think that we need to be very, very careful about this. It should under no conditions ever be a reason for changing personal protective equipment status in healthcare workers. And surely with the more than up to 1/2 of all the positives not being true positives, under the average condition of these tests that are out there, I think that that would be really a problem. So again, I refer you back to our document and the work that we've done on this issue, and just say that at this point, I think that it's fair to say that we still have a long ways to go in having the smart testing we want and need in this country. So thank you very much. And again, I apologize for not being able to have access to my slides or on the video here.
Well, thank you, Dr. Osterholm. We're just so pleased to have you be able to join our panel this afternoon. So this is one more question, a final survey question for the group, and you'll see that on your screen. If you can participate in that, we'd appreciate it. Okay, and I'm having a little technical difficulty on my end, so I can't see the response, but hopefully you all can. And I just want to mention at this time, our formal presentations are completed, and I invite everyone to continue to submit your questions to the question and answer box located at the bottom of your screen. During our presentation, we did have numerous questions come in, and I'm just going to ask a few of those of our panel. And I hope that you all on the panel will be able to jump in. One question, our mom was COVID-19 positive with no symptoms in a nursing home, but she's now had 2 negative tests. What should she have? Should she have an antibody test, and when? And how vulnerable could she be for the reinvention to a mutation? So would one of our panelists like to take that?
Could you clarify, this is Mike, could you clarify again, she was positive at one point?
Our mother was COVID-19 positive with no symptoms in the nursing home. Now she has had 2 negative tests. When should she have an antibody test, and how vulnerable could she be for the reinvention to a mutation?
Well, first of all, I will just add my 2 cents worth, and there may be a different opinion. I don't think she needs any more testing. I think the bottom line is that, again, the likelihood of being a false positive PCR is very, very low. The idea of having a false negative is more substantial, even though that's not that high in PCR testing. We have no data at all that mutational changes have any impact whatsoever on these testing. We've been very involved with looking at the changes over time. with these viruses, and we have no data at all that support that there are mutational changes that have materially affected either the PCR or the antibody testing on this issue. So I wouldn't be concerned about that at all. The mutational changes we see in these viruses, which we're monitoring very closely, are more the kind of changes, if I use an analogy of what a picture might look like of you, when you're 5 years old, 10-year-old, 20-year-old, and 30-year-old. It's still the same you, but you look different. That's the kind of changes we're seeing in this virus, nothing that materially impacts its pathogenicity, virulence, or transmissibility.
Okay, thank you.
And I would just add, Deb, that I think as Dr. Ostholm said earlier, these tests that are being done, especially at a nursing home, should in no way dictate how the nursing home changes the important issues about social distancing and caring for this at-risk population.
Thank you, Dr. Rizzo. Dr. Mora, a question for you, I think. Is someone who is severely affected by seasonal allergies more susceptible to COVID-19?
Actually, we wrote a blog on it, and one of the actual things that we learned was actually having allergies might be a little protective for COVID-19. Because just to get a little nerdy here, actually it's an enzyme that's upregulated in people who have seasonal allergies that's a little protective towards actual COVID-19. Although one thing I will say is a big question I always get from my own patients is it's been a hard actual time to be in a pandemic and have seasonal allergies at the time because you're sneezing through a mask and you're actually having a very runny nose and maybe a sore throat. And the big question is, do you have COVID-19 or do you have seasonal allergies? Remember, I always remind patients, if you seasonal allergies come with itchiness, with actually runny nose, itchy eyes, etc., and it's nothing different from what you already have versus COVID-19 that tends to be, a respiratory virus, the loss of actual smell or taste, shortness of breath as well too, cough that can occur, etc.
Thank you. One last question, and I just want to let everyone know there are so many questions in the Q&A, and we don't want to keep you over the allotted time frame, but we will be answering the questions, and we will follow up via an email to the email address that you provided when you registered for this webinar. So be assured that your questions will get answered. We just may not be able to do it here. So one last question, and Dr. Osterholm, we're going to, again, give this to you, is could you comment on or share your opinion on the testing that's begun on asymptomatic people from mass gatherings like vigils or cleanups or protests? And particularly in Minnesota, per the Minnesota Department of Health's recommendation, the second part of that is, are those drive-up tests still helpful given when you mentioned that there's missing information, data, et cetera, and is it helpful to be tested for asymptomatic people?
Yeah, well, first of all, thank you. Let me just say very briefly, we don't know at this point what will happen in terms of the number of cases that may increase with regard to what happened with our recent protests and the crowds that came together. The one thing we have in favor is they were largely all outdoors, and in that regard, the virus tends to dissipate quickly into the environment, into the air. Any air movements move it fast, and that surely reduces the exposure issue. I would say that if you look at Wuhan, out of 327 different clusters that were investigated, only one of those were an outdoor get-together, all the other were indoors. Now, granted you, it was December and January, that may have surely had an impact on that. We know that from 1918 that there were actually increases in cases that occurred in several instances where they had war bond parades that were actually ill-advised by the public health, but they went ahead with them anyway. And so there was an outdoor where there was some transmission. In terms of other risk factors, we know that the tear gas and the smoke caused increased coughing in a number of people, which by itself could be an aerosolizing event. We also know loud voices, singing, shouting, also are potential for aerosolizing virus. And so that surely could increase the risk too. Finally, those who were basically arrested put into holding vehicles, usually buses, for a period of time before they were transported to the jail. There they were booked, put in jail, which we know also as a congregate setting can surely increase transmission. So the bottom line is we're all waiting. We don't know the contribution this will make. In terms of testing, the idea that if you're testing someone for antigen or for the virus itself, with PCR, the molecular diagnostics testing, those are things that you should at least wait 7 days after you were there or your last exposure, just to be certain that we don't have a false negative, in the sense that you really would be positive, but the virus just hasn't gotten to a level yet that you might be found positive. We know you can clearly be positive days before you actually get clinically ill, or of course you may be asymptomatic. So most people right now are at that period where they could be tested and the increased likelihood of being picked up as a positive. Of course, if they become ill, then we want people tested. Today we have our first reports out of increased testing positive in the National Guard who are in Washington, D.C. area. We're seeing an outbreak that looks like it is occurring there in that group. So that would suggest that there surely could be an increased risk, and we need to be mindful of that.
Right. Thank you. And again, just being respectful of everyone's time, we've really come to the end of our program, and I want to thank everyone for attending. With so many participants, as I said, we have not been able to answer all of the questions, but rest assured that we will be following up with you, and any unanswered questions, which there are a number of, we will make sure that they are answered and that we send that whole question list to everyone who has registered for this webinar. And then just on a final note, I want to make sure that everyone marks their calendars for the July and August town hall meetings. July 15th, we'll be talking about air quality and COVID-19. And then on August 12th, we'll be talking about COVID-19 and mental health. And so we hope that you will join us for those particular town hall sessions as well. And we thank you for joining us today. Have a great day.